Denmark historically spent 25 years ago, 8% of its GDP on healthcare. In the last 20 years, that number grew noticeably by several points, as high as almost 11% of GDP in 2021. Did that increase happen intentionally? But what do you think is the right number? Use the US as another benchmark where we've been at 17.5% of GDP for the last 15 years.
We don't need more money than we're getting all. And the reason for that is that we have already a lot of resources that we're not using probably. So what I'm saying is that we waste our patients' time with some medications that is not giving them the value it should do, some tests, some diagnostics, some treatments, some rehabilitation program that is actually not giving our patients any value. The extent of that, it's large. The OECD has said that 20% of what we're doing is waste.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right. Welcome, Rasmus, to the latest Analyzing Healthcare podcast with Scale Community.
Thank you very much, Roy.
I would say good morning to you, but I know it's afternoon where you are. So good afternoon.
Hello. True. It's afternoon here in Denmark, Copenhagen.
Okay, so for our audience, you're the CEO of Rigshospitalet. I know my pronunciation is dreadful. You don't have to tell me. But the research I've done on this hospital is it's if not the largest, one of the largest hospitals in Denmark with over 1,000 beds. 12,000+ employees, 2,500 doctors, over 4,000 nurses, 1 million outpatient visits per year. So all in all, a very large hospital. Is that a fair description?
That is a fair description. Also the national hospital with the tertiary and most of the quaternary functions in Denmark.
Okay. All right. So Denmark is often referenced as a case study in efficiency and equity, a very vibrant, healthy system, and it's also a single payer system at that. So I think it lends itself to a really good case study for us all to explore and ask, why is it working? And I want to draw contrast, if I can, with the NHS in the UK, where nothing seems to be working. So let's start there. Why has Denmark been able to provide high quality care? And feel free to push back on any of my assumptions, whereas the UK has 10 million people on a waiting list, has strikes, it seems now on a perpetual basis, whether it's doctors or nurses, is constantly cutting, constantly restructuring its model. Every year there's an NHS effort to restructure what it's built. Now there's going to be issues regarding drugs because they're facing pressure from the US to elevate the prices that they're offering, overseas drugs. It's just constant chaos in the NHS. And it seems to be getting worse, not getting better. How does Denmark contrast with that, given that both countries are using a single payer system?
Thank you. Very interesting question, Roy. I will agree on you that the Danish and the Nordic healthcare system are at a far better place than NHS and the U.S. Definitely. But just to declare, we also need to get much better. We are also facing challenges that we are dealing with. But to start with, the question is, are the Danish healthcare system and the Nordic healthcare system at a better state? Yes, we are. And why is that? When I look at the other healthcare systems in Europe and in the world, there's no doubt that we have gone through a very large centralization. So when you look at Denmark compared to, for example, Germany has nearly 7 times as many hospitals as we have in Denmark per inhabitant. So we have centralized a lot in Denmark, and we have worked with getting national recommendation on how we treat people. We have worked a lot together in the medical society and Liverpool research societies on finding a national standard. And I think that is one of the keys for where we are right now. We also have to say that we are a small country, which we are only 6 million in Denmark. And that makes it far easier to gather the entire ecosystem. So we are actually sitting all of the partners from the ecosystem, industry, university, health services, patient and organizations, hospitals, policymakers, and regulators. We're sitting together. I'm part of the government's council on life sciences, and we are sitting 20 people representing the entire ecosystem and coming with advice on a national level on what we should do to improve not only healthcare, but also life sciences, so they interact much better. I think these are some of the things.
So what would you recommend to the German populace, given the contrast in terms of number of hospitals? You mentioned 7 to 10 times the number of hospitals on a per capita basis. Should they be going down a consolidation path similar to Denmark and moving into less but much larger, inverted commas, super hospital formats? Is that a winning strategy, or are you seeing price that you pay for larger hospitals too, as one would expect, diseconomies of scale, bureaucracy, inefficiency, complexity? Which of those two strategies do you think is the better strategy, more hospitals or less larger hospitals?
I think that you need to centralize to begin with, to accumulate knowledge and have a sufficient amount of patience and expertise around an issue. And then you have to decentralize the services. So I think we have gone through a lot of centralization, which has had a great influence on skills and knowledge. We have a huge research facility with thousands of researchers working at the hospital, more than 160 professors, nearly 4,000 students just working within this field. And then now our aim is to decentralize the knowledge, to decentralize diagnostic treatments so they can actually be done at home. And that is what we are trying. So we are saying that we have a global problem with workforce shortage, the double demographic pressure, people getting older with more diseases. We can do more, but we are less to actually do it. So we need to do something differently. And one of the things is that it makes no sense that we move people around, neither patient or staff, if it's possible to do it on the distance. So right now we are at the stage where we have been centralizing that much that we are actually able to do things as close as possible to the patient. And for a lot of things, even at their own home. I can give you an example. So during the last years, we have worked with hematological cancers. We have patients from very far away coming to Copenhagen, but now we educate them in how they do mix their own chemotherapy and how they do all the treatment at home. And if there is a problem, we have established a call center. So now for a patient with oncology treatment, they are treated at home. They do it themselves. If there is any issues, they just phone the call center. And instead of using what is close to a year within hospital, they only use 7 days. And this is now possible for all ages. So we also treat parents when their kids have leukemia, for example. And 75% of all our patients is able to do the treatment at the highest quality standard at home. 25% is not, and they are then admitted to hospital because of lack of resources or compliance issue, or simply because they are not feeling safe enough to do it at home. So that's just an example on so what you can gain when you centralize knowledge, and then the purpose is naturally to decentralize it again, so it actually is of benefit for the patient, as close as the surroundings they live in.
That is really interesting, that the whole concept of plurality, fragmentation versus centralization and normalization is a continuum. It's not necessarily a fixed point. I think that's really interesting, that you centralize in order to decentralize. That hasn't been expressed or explained to me in the past, and I really like it. Denmark historically spent 25 years ago, 8% of its GDP on healthcare. And I'm looking up, doing some research real time. In the last 20 years, that number grew noticeably by several points, as high as almost 11% of GDP in 2021. 2023, it came down again to 9.5%, but still a percentage increase in healthcare spend is noticeable. A 2-3% increase is a revolution. Did that increase happen intentionally? Did the country believe that 8% is just too low a number? There was underinvestment in healthcare. What do you think is the right percentage to spend on healthcare? And I know it's a very loaded question because it depends how that spend is happening. Is it waste? Is it investment? Is it cutting edge? Is it digital? Is it bureaucracy? Is it union wages? Where it's going. The anti-capitalist audience that listen in would argue, is it excess profit? Loaded question. But what do you think is the right number? Use the US as another benchmark where we've been at 17.5% of GDP for 15 years.
It's difficult to say what the right number is. That might vary. I think that the changes you have seen has actually been due to, at a large point, to investment in areas where we needed to renew primarily the diagnostic area in Denmark. And that was largely due to the cancer treatment and what was done in that area. But I will say it short, we don't need more money than we're getting. And the reason for that is that we have already a lot of resources that we are not using probably. So what I'm saying is that we waste our patients' time with some medications that is not giving them the value it should do, some tests, some diagnostics, some treatments, some rehabilitation program that is actually not giving our patients any value. The extent of that, I do not know, but it's large. I believe that. So the OECD has said that 20% of what we're doing is waste. We don't know that exactly, neither do them, because nobody is doing it intentionally. But I can tell you that the majority of a clinician now in Denmark believes that...
By the way, 20% waste is a number to be proud of compared to most countries.
Yeah, but now you said 10% of the GDP. I mean, if the US is 70% of the GDP, it might be a higher extent. But now I'm just saying at what I know about and not going too much into detail about other healthcare systems. But at least when we look at Denmark, the majority of clinicians believe that we actually are wasting our patients' time, are wasting our resources, doing something that is not providing enough value for our patient, and some of it might even harm our patients. So when you ask what is the right number, I will say we should start investing in identifying what is of either low value or is harmful to our patient. Stop doing that and redirect it into what is of high value to our patient. And I don't need the government money to do that. I actually think that we can do that together in public-private partnerships, develop these mechanisms that actually identify that. And we're doing that right now. So we are working in something we call platform trials, which is a sort of a research engine where we do the randomized clinical trial with multiple procedures, treatments, tests, whatever. It can actually test what we do in daily clinical life. So that has been built so you don't need to be a scientist to be part of it. So the software has been made easy for the clinician. So when you order something, it says that we got another thing that we're testing right now and prescribe that instead, for example. And what you need when you do that is that you need a huge number. So now we are working with all the hospitals in Denmark, but also in the Nordic countries. That means Iceland, Norway, Sweden, and Finland. And that is not now only 6 million people. Now it's 30 million people altogether. And the thing is that we want to make it easy to test daily clinical life in a setting where we can actually say that we test all the antidiuretics, all the anticoagulations, all the fluid therapy, for example. But it could also be all the procedures of rehabilitation or whatever. And when we find out that something is of low value, we can stop it throughout all 5 Nordic countries.
How do those Nordic countries compare in terms of their healthcare system, particularly on data and organization? Are they like Denmark, where they have a centralized registry? Are you finding it relatively seamless to share data across these different nation states? Do some countries outperform others? How would you rank?
Nothing is simple and easy in healthcare, but we are very alike. We got the same healthcare system. We have the same value. If you go back, we have been part of each other's country for, 1,000 years ago. The borders have been changing all along. So we have a lot of things in common. When we ask Danish patients if they need another treatment, do you want to go to Norway or Sweden or other countries? They always say 100% Norway or Sweden. So there is already many similarities culturally and value-based. But if it's seamless, no. It's not seamless because it is 5 independent countries. So that is what we have been working on. How do we get data to cross borders?
But it sounds like you've been successful despite the disparity. Differences in data accumulation, data terminology, and you've been able to actually consolidate data for the sake of research across these different countries. Is that right?
Yes, but only in a project-wise. So we have to do it within that specialty. Let's say intensive care medicine. Then we have worked at it as a project. What we want to do is in what we call the Nordic University Hospital Alliance, which is all the hospitals in all of the 5 Nordic countries, but led by the capital hospital in each of the 5 countries. That means Reykjavik, Oslo, Stockholm, Helsinki, and Copenhagen. We want to make one virtual Nordic University Hospital. So it is actually seamless also in everyday life.
That's fascinating. That is really cool. I'm looking forward to that. A virtual Nordic hospital. Forming your own version of the EU, but a Nordic version.
No.
I love that.
People can join along on the way, but we just have to start where it's easiest and then pave the way for a way to collaborate.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire life cycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered RCM.
Great.
All right. So unlike the UK and the NHS, that sometimes I think falsely gets credit for a integrated EHR system with a single repository of data on all of its patients. And I think that's false because when I speak to operators in the UK, nothing speaks to nothing. Everything is dysfunctional. Everything moves at a snail's pace, measured in years. So there is no cutting edge digital healthcare footprint all over the UK. It's a total mess, an underinvestment mess. I look at Denmark and it feels like you might be a winner here in terms of really understanding your populace. You do have a single registry. It is organized. The systems do speak to each other. Knowing what you know about other countries that don't have, beyond the UK, but the whole world that hasn't been able to in any given country organize all of its patient data in one place, true interoperability across all providers. Are you able to benefit today from that kind of information, access to information? And in what ways? What would be the benefits for us here in the US? We're spending a lot of time and effort now on interoperable data because we've suffered from siloed data now for too long. The Cerners don't speak to the Epics, and the Epics don't speak to the eClinicals, and the eClinicals don't speak to the Athenas, and it goes on and on and on. And payers don't speak to each other, and providers don't speak to each other. So it's all disparate data, independent progress as opposed to coordinated progress. So what are you seeing as the fruits of your coordinated data that we could look forward to?
I actually think that there are quite some fruits. But just to declare, everyone, when you have what you have, you always want something more. So right now, just to say it, we are not content with the state where we are. We want it to get even better because we can see what we can gain from getting it even better. But right now, it is like that we have one national system for a patient, where the patient can go in on an app or a computer and see all the diagnostics on all the journals that has been done at every hospital in Denmark. And that means for the patient that they can actually go to a doctor in one place, they can go to a test in another place, they can go to an MDT and a physical examination in a third place, and they can be operated on a fourth place, if that's meaningful. But just saying that data can travel and follow the patient. And we can see it real lifetime when if do a cardiac procedure at one university hospital and colleagues can look at and discuss it real time at another university facility. Even at remote distances, we can do the same diagnostics as we do at the quaternary university. So right now we are able to do the most advanced cardiac MRI scans at Greenland or Faroe Island or some of the other islands we have in Denmark at the same level as we do at the university hospital, and without even the radiologist or the sonographer being there, but sitting on the distance controlling the scanner. We have started performing neurosurgery at a distance, training the broad surgeons for a couple of weeks, and then when they see a patient 3,600 kilometers from Copenhagen, they can put on VR glasses and is guided by a neurosurgeon far, far away. And that has actually saved lives now. And we want to do that in an even bigger extent, using that we are very digitalized, that we have the same system, that we can do this real time. Other benefits is when we look into the data, we have a lot of knowledge where we can actually try to tailor therapies better for patients. So we can do simple statistic on the last 20,000 patients in Denmark that have been through this and this procedure and see if something should be done differently. We can benchmark hospitals and see why do they perform better at this hospital than this hospital, and actually have a very detailed discussion about that instead of just having what it appears, actually have thorough data to talk and learn from. And then it's I think it's an infrastructure that we use when we, as I said before, when we are decentralizing test, diagnostic skills, whatever, when we're actually doing hospital at home, when that is actually there where we use the digital infrastructure. And I can give you an example. During COVID-19, it was really saw a big difference between other countries and the Nordic countries in terms of how we use digitalization. And I know that in Denmark, we started having therapy like the rest of the world that actually not cured people for having COVID, but the most vulnerable patient didn't go to ICU. So we actually make the condition milder. And what we was able to do was that we could list all the high-risk patients, and then we could follow if one of these high-risk patients went to one place in Denmark, had a test, and they were tested positive. We could phone them immediately and say, you have a positive test, go to a GP, and he already knows what he's going to do. And if the GP said, I'm not really fond of doing this, they went to a hospital and then they had the treatment there. And that meant that we had nearly no patients in ICU during wave 2 during COVID. So that's just an example on how you can use a digital infrastructure and using your data for the purpose of our patients.
Are there other countries outside the Nordic region that you look at to emulate? Things that they're doing well that you keep a close eye on, whether it's clinical research or coordinated care, whether it's Mediterranean countries or parts of Asia, whether it's different forms of reimbursement models. Where do you look for inspiration from other parts of the world?
When it comes to strict clinical, we have many collaborations throughout the world, especially US and Europe. Also, we have a lot of research collaboration throughout the world. At this hospital, we have 4,000 scientific publications a year. 100 students is graduated from this hospital. So, and all of them are with international collaboration. So in that terms, we need to have a global view. But when you talk about where do we look to organize differently, I must be honest and say that we most look at countries where they have healthcare system like us, because we can see that we have a different perspective in the public funded healthcare system, because we are not profit-based, we are value-based. So I got a budget and I have what we call a population responsibility. I have to be, I'm measured on how much value I bring to that population. So when we talk about the double demographic pressure, that is something I find mostly that we talk about in the Nordic countries, in England, in Holland, the Netherlands, where a lot of other healthcare systems focus on the workforce shortage, not whether we should stop doing test procedures. They're not that focused on that part. So I think we generally look most toward the countries that have similar healthcare system when we're talking about organizational changes.
Let's dig into that a little bit deeper. What do you mean by not focused on, you mentioned the workforce shortage. Just explain that to me.
Yeah. So I mean, when you look at the mean lifetime expectancy, it was 50 years in the start of the 19th century. Now it's above 80 in most European countries. So we live longer. That is fantastic. But that also means that we live with more comorbidities. We as a healthcare system can do much more. We have much more to offer. So demand is rising exponentially. When we look at the workforce, that is declining in every European country. The fertility index has to be 2.1 just to keep the population stable. There is none of the European country who has such a high fertility index. On average, it's 1.38. That means that in the next couple of generations, we are halving the population. So we are less there to help the elderly patient. So that is what we are very focused on how do we remove our resources from what is either harmful or produces low value into what is producing high value. And we can afford that because we are value-based. If you are profit-based, you need to see to that you can actually keep an income on what you do. And you will have a much sharper view on how do I increase my workforce. I'm not saying that my colleagues around the world is not looking into removing what is of low value, but our incentive is much bigger. And with that also comes responsibility to find out what is actually of low value. So colleagues in other healthcare systems from that.
Got it. So in addition to remote care, which has been a uniquely Nordic challenge, which Denmark and other countries have risen very well to that challenge and provided integrated care, digital care, and remote care in ways that are example to other countries. You also have a problem that we all share, which is in different degrees, which is a shrinking workforce. So that's another secular challenge that the system, the healthcare system that you have has to respond to. I understand. What I want to do is maybe finish on this question of budget, of annual fixed budget versus fee for service. If we were to take the contrarian view of a fixed budget and criticize it, whether it's no system is perfect. What are the limitations, the shortfalls of having a fixed budget? Is it disagreements with whoever is influencing those budget decisions because they just aren't responding to shortfalls in investment and spend? Is it a little bit more confusion over market signals because you can't react to profit, you can't react to price increases? It's not that kind of market signal that you're responding to. I mean, you're obviously tracking volume. So you're seeing increases in need for oncology care or increases in cardiology. You're seeing that. But I'm just wondering, when you remove fee for service and you remove the increase in revenue that comes from increase in usage, you're creating an indirect pathway towards more dollars spent. You have to show up with that fixed budget at the end of the year and say, I need a much larger budget for my ophthalmology wing, because it turns out there was much more usage than we anticipated. We ran out of money. And what often happens is the signals get confused because before the volume even picks up, someone in the hospital is damping down demand. Supply is constrained because of a fixed budget. So you're actually pushing patients away. And the way that you do that is with a waiting list. Yeah, I would love to give you an ophthalmology procedure, but that will be in 2 years' time. Sorry, goodbye. This is our budget. In fee-for-service, that doesn't happen. If there's more patients needing more ophthalmology procedures, they get them. And then everyone complains that the system has gone crazy because everyone's overspending on everything and no one really knows what they actually need. And there's just too much supply satisfying too much demand. And so it's this concert balance, it's this music that's being played between different economic philosophies. And I don't think either one of them has gotten it perfectly right. So if you were to take the other side of this argument, what is wrong with budget medicine? What would you say?
What is wrong or what is right?
What's wrong? I know you like it. Now I'm going to force you to be uncomfortable and criticize it.
Okay. So
what doesn't it do well? I mean, I'm a big believer in nothing is perfect. Nothing is perfect.
Okay. So you have said a lot of things, and then I will say what can be the challenges. So what is the problem is that you cannot just add a lot of activity in order to make a huge economic buffer that you then can use for investment. You have to go other ways in order to get that seed money for investment.
You always have to justify your money. Whereas if you generate a profit, you really don't have to explain it to anyone. You have the money, and if you want to reinvest it, you get to reinvest it. It's yours.
Exactly. So you need to find ways on how do I invest in new treatment, something that has not been proven, research, and that is one thing. We have found ways of going around that, but that is one of the issues. It can also be to invest in something that will be a business case in 5 years from now. That is difficult when you have annual, but we try to find ways for that.
By the way, it was the Nordic writer that wrote probably the best business book ever written. I'm guessing he was Nordic because his surname was Christensen. It sounds very Danish. As a Harvard professor who wrote The Innovator's Dilemma. And I think that's the best business book ever written. And I'm not alone in saying that. And his book really described the U.S. versus the rest of the world. And it makes the case that the U.S. has been for the last 200 years the most innovative place in the world, because he didn't really say this, but he sort of said it, because innovation is the messiest place you can possibly find yourself, with the most amount of loss and waste, even more than fraud. There's more money wasted on innovation than there is on fraud. I promise you. It's not even close how much gets created that ends up getting put aside or written off because it didn't work. And that's the inherent speculation, the unknown of investment. And the easiest way to fund that is not through a government budget. I mean, you will get some money towards innovation through a government budget, especially a good government that has, long-term horizons and has a means to invest in the future. But the easiest way to fund it is through profit. And whether it's your own company's profit or whether it's your LP's profit, which is the venture capital community, right? Bringing in other companies to invest in your company, whether it's tax efficient companies, foundations, or whether it's very successful companies like Google venture capital. Ultimately, the redistribution of profit in order to invest in speculation. No country has been more profitable than America over the last 200 years. There's just so much money to go into innovation and then destroy most of it. But it's the part that doesn't get destroyed, which is really special, right? It's the stuff that works. So you don't have that luxury in Denmark. You have to fight for that budget to fund innovation. And yet you're still innovating quite well, which is quite remarkable. And that's what you don't really see in the NHS. You don't really hear these stories of cutting edge innovation. It's not really there. So there is a real contrast.
Yeah. So it needs a lot of work on getting the funds, and especially to do all this innovation. It also requires to work together with private or commercial vendors in order to invent new things. And so we are largely dependent on external funding and public-private partnership in order to do innovation.
Like a Novo Nordisk Foundation to co-invest.
Yes, exactly.
Are there growing numbers of public-private partnerships in the Nordic region?
Yes.
Are there examples that you can speak of?
Yes. So what we try to do with the public-private partnerships is to make them real partnerships. So we have numbers of partnerships where you can say it is a luxury vendor-seller relationship. And then we have moved it into to be more real partnership. And we do that with only a few at a hospital level. Right now it's Johnson & Johnson, it's Roche, it's Siemens. We are strengthening our collaboration even more with Medtronic. But we think that there is a fixed amount of how many public-private partnerships we can have when it is at that level that you're doing now, where we use year together to align strategies, to find common ground on where we both partners want to invest, to make mission-driven purposes, where we as a hospital don't want to buy what is already in stock, but we want to co-create new solutions, but also where we know that we should not come up with the solution ourselves, but only present our need. And then finally, we want both partners to invest in staff that is actually working alongside in the hospital with our patients, with our clinicians, developing solutions that can actually scale, at least in the Nordic countries. And the best public-private partnership is when we also have private partners that agree on they go together and work on a common mission, a common theme. So only a few large, real public-private partnerships.
And I imagine they don't lack for funding.
No. Then when you spend the time on revealing what you want to solve and that mission makes sense for all of the partners, then it is not resources that is the problem. And the thing is also that it is very difficult as a hospital to work with very small startups. We need public-private partnership to embrace those and put them into play. On the other hand, it is very difficult, very cumbersome to work with all the regulations and things that are data across borders and whatever. And that is only possible for the very large hospital to be able to do that. So our responsibility is to bring in the smaller hospitals, the GP sectors, the primary sector, the children's sector. So we need the large players to work together in a partnership, but they also have to bring the entire ecosystem into be part of it.
Yeah, that's quite common. We do see large hospitals that tend to work better with other large groups. It is all a grand experiment, right? The public-private partnerships that you speak of, I imagine, and I would have guessed those private partners are mostly life science partners because they have a different system in your country. They're able to sell devices and drugs for a profit. So they're motivated to be with you. But what you don't have is public-private partnerships with other healthcare provider organizations because they're not able to function the way they normally would in your country. They would have to go and advocate for their own budget, which is mostly not how they do business. So you are missing out on those partnerships and they are increasingly valuable. I can tell you, as the definition of what it means to provide care changes, especially with the introduction of AI and virtual care and digital care and international care. The old paradigm of the only thing international in healthcare is Pfizer is going away, or Roche. And you're going to find more and more large international healthcare companies like that are Amazon in size and don't sell a single drug. They provide care. And they're going to want to participate in Denmark with you. And then you're going to have a challenge. How do you get them excited? If all you can do is offer them a piece of your budget, which is not really how they think about the world. So it's complicated. Nothing is easy and everyone has to sacrifice in healthcare. In the U.S., we have hundreds of different ways for groups to get incentivized. Employer self-insured, alternative insurance, cash, debt finance, patient care, not to mention obviously all the different government programs, all the different commercial programs, all the special programs like ACA or ACO REACH, philanthropic programs. There's hundreds of different ways to incentivize the provision of care. But what we don't have is coordination. We have these siloed pockets of solutions that don't really speak to each other. So nothing is perfect, but it is interesting how these things evolve over time. Rasmus, I really want to thank you for your time this morning, and I look forward to us staying in touch and continuing to explore different ways to build a healthcare system.
It's really a pleasure. Have a nice day.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.